Let's start with a real-world case that demonstrates a typical presentation. A 27-year-old woman presents to the clinic with several days of fever, chills, headache, malaise, loss of appetite, and abdominal pain. Today she's particularly concerned because she noticed her eyes have turned yellow, that's jaundice, and she's developed intense, generalized itching, which is really bothering her. When asked about risk factors, she admits to using intravenous drugs for the past few years, and frequently shares needles with friends. She's had one sexual partner in the past year. These two key risk factors, IV drug use with needle sharing and sexual contact, are classic routes of hepatitis B transmission. Keep these in mind as we explore this virus. Before we dive into pathogenesis, you must understand HBV terminology. There are three key antigens, and this can seem confusing at first, but let's break it down systematically. First, HB's AG hepatitis B surface antigen. This is found on the surface of the virus and is detectable in large quantities in serum. There are several subtypes. Think of this as the virus's outer coat marker. Second, HBe AG hepatitis BE antigen. This is associated with the viral nucleocapsid and indicates active viral replication. Importantly, it circulates as a soluble antigen in serum, separate from the virus itself. When HBeAg is present, it means the virus is actively multiplying. Third, HBcAg hepatitis B core antigen. This is the core protein of the virus. Here's what's crucial. HBcAg is only present inside infected liver cells. You'll never find it circulating in the blood. This is why we test for antibodies against it, not the antigen itself. Now let's understand the antibodies against these antigens. This is critical for interpreting lab results. Anti-HBs, antibody to surface antigen. This indicates immunity. You'll see this in three situations: past infection with recovery, passive immunity from hepatitis B immunoglobulin, or successful vaccination. If you have anti-HBs, you're protected. Anti-HBe antibody to E antigen. When an HB's AG carrier develops anti-HBe, it suggests lower viral replication and lower infectivity. Think of it as the body starting to control the infection. Anti-HBc, antibody to core antigen. This indicates HBV infection at some point in the past. It could be recent or years ago. The antibody doesn't tell us when. Finally, IgM anti-HBc. This is the IgM class antibody specifically. This indicates recent or acute infection. IgM anti-HBc stays positive for 4 to 6 months after infection. This is your marker for acute hepatitis B. Unlike hepatitis A, HBV is not transmitted fecal-orally. Instead, it requires blood or body fluid contact. The main routes are parenteral, through blood. This includes IV drug use with shared needles, as in our patient's case. It also includes needle stick injuries in healthcare settings, contaminated medical equipment, and blood transfusions in areas without proper screening. Sexual transmission is another major route. HBV is present in semen and vaginal secretions. Perinatal transmission occurs from infected mothers to babies during childbirth. This is particularly important because babies infected at birth have a 90% chance of developing chronic infection. Unlike hepatitis A, casual contact doesn't spread HBV. You need direct contact with infected blood or body fluids. Let's follow the virus through the body and understand how it causes disease. After entry into the bloodstream, the virus reaches the liver through the blood circulation. In the liver, HBV infects hepatocytes and begins replicating. Here's an interesting point. Like hepatitis A, HBV itself is not directly cytopathic. It doesn't kill liver cells directly. From the liver, viremia occurs. Virus enters the bloodstream again and spreads to various body secretions, including blood, semen, vaginal fluids, and saliva. This perpetuates the transmission cycle. So how does liver damage occur? It's cell-mediated immunity and inflammation. Cytotoxic T cells recognize and destroy infected hepatocytes to eliminate the virus. This immune response causes the symptoms and, if successful, resolves the infection. However, if the T cell response is insufficient or the immune system cannot completely clear the virus, chronic hepatitis develops. This is the key difference from hepatitis A, which never becomes chronic. This diagram shows the possible outcomes after HBV infection. About 95% of adults who contract HBV will develop acute hepatitis, but their immune systems successfully clear the virus. This is acute infection with recovery. However, approximately 5% of infected adults cannot clear the virus and develop chronic infection. This percentage is much higher in infants. Up to 90% of babies infected at birth become chronic carriers. Chronic infection can lead to serious complications: chronic hepatitis, cirrhosis, and hepatocellular carcinoma. This is why HBV is considered oncogenic, it can cause liver cancer. This graph is essential for understanding acute hepatitis B. Let's walk through the timeline carefully. After exposure, there's an incubation period of 45 to 160 days, much longer than hepatitis A. The average is about 60 to 90 days. HB's AG is the first marker to appear, showing up before symptoms begin. It remains elevated throughout the acute illness. When symptoms start, liver enzymes like ALT spike dramatically, indicating hepatocyte destruction. Shortly after, IgM anti-HBC appears. This is your confirmatory marker for acute infection. It stays positive for about 6 months. As the infection resolves, HB's AG disappears from the blood. This is followed by the appearance of anti-HBs, the protective antibody. When anti-HBs appears, the patient has recovered and is now immune. There's an important period called the window period between the disappearance of HB's AG and the appearance of anti-HBs. During this time, the only way to diagnose recent infection is by detecting IgM anti-HBC. Finally, anti-HBC IgG persists for life, serving as a marker of past infection. In chronic infection, the serological pattern is completely different. HB's AG persists. It doesn't disappear. This is the hallmark of chronic infection. If HB's AG remains positive for more than 6 months, the patient is chronically infected. HBeAg may also persist, indicating ongoing viral replication and high infectivity. Some chronic carriers eventually develop anti-HBe, suggesting lower viral replication, but they're still infected. The critical point: anti-HBs never appears in chronic infection. If you see anti-HBs, the patient has cleared the infection. The absence of anti-HBs with persistent HB's AG defines chronic hepatitis B. Anti-HBC IgG is present, but crucially, IgM anti-HBC is negative in chronic infection. IgM indicates acute infection only. How do we diagnose hepatitis B in the laboratory? The primary method is serological testing using ELISA to detect HBV antigens, specifically HB's AG and HBeAg, and antibodies against surface and core antigens in the patient's serum. Additionally, we can detect viral DNA by PCR. This molecular test is particularly useful for monitoring chronic infection, assessing viral load, and determining treatment response. High viral DNA levels indicate active replication. The combination of antigen, antibody, and viral DNA testing gives us a complete picture of infection status, stage, and infectivity. Now let's interpret serological results. This is crucial for clinical practice. I'll go through several scenarios. First scenario: all tests negative, HB's AG negative, anti-HBC negative, anti-HBs negative. This person is susceptible. They've never been infected and have no immunity. They need vaccination. Second scenario: HB's AG negative, anti-HBC positive, anti-HBs positive. This person is immune due to natural infection. They had hepatitis B in the past, cleared it, and now have protective antibodies, plus anti-HBC showing past infection. Third scenario: HB's AG negative, anti-HBC negative, anti-HBs positive. This person is immune due to vaccination. They have protective antibodies, but no anti-HBC because they were never actually infected. They were vaccinated instead. This is the pattern you want to see in vaccinated healthcare workers. Two more critical scenarios: acute infection, HB's AG positive, anti-HBC positive, IgM, anti-HBC positive, anti-HBs negative. The presence of IgM anti-HBC is the key. This specifically indicates acute or recent infection. HB's AG is present because the virus is still active, and anti-HBs hasn't appeared yet because the infection hasn't been cleared. This is exactly what we'd expect in our case patient. Chronic infection: HB's AG positive, anti-HBC positive, IgM anti-HBC negative, anti-HBs negative. Notice the critical difference. IgM is negative because this isn't acute. HB's AG persists beyond 6 months. Anti-HBC IgG is present from past exposure, but anti-HBs never appears because the virus was never cleared. The key differentiator between acute and chronic: the presence or absence of IgM anti-HBC and the duration of HB's AG positivity.